So we already went over like acute respiratory failure and ARDS. Okay. So if we talk about endotracheal tubes and tracheostomy, so this is the part that we talked about, ET tubes and tracheostomy. This came from the lab lecture. Remember we were talking about. So the important things that you need to know about that is you need to make sure that you know the size of your trach and the size of your ET tube. Okay. We have to make sure we mark it as a landmark, so much at the lip. So check the size, 23 centimeters at the lip. So we know exactly where that ET tube is at. Your tracheostomy, it's really important because remember, we have to change that inner cannula. So we're changing that every shift. So if you have a number 8 shyly, you need to make sure that you have a number 8 inner cannula to change that. So it's really important. Remember that we suction as needed. Don't forget your suction procedure. So why does your patient need suction? Making sure that we're not over suctioning somebody that has increased intracranial pressure or high ICP, right? Making sure that we hyperoxygenate them before we suction them. We can never suction more than 3 times, and making sure that we're waiting 1 minute in between. Before they used to say suction every 2 hours, just keep suctioning the patient. But now we've learned that over suctioning patients also causes damage to that carina and the epithelial lining of the lungs. So suctioning patients as much as we want to also doesn't provide a benefit. So please make sure, usually when I'm suctioning my patients in the ICU, I have my stethoscope like kind of around my neck. And then as soon as I suction them and I give them a second and I'm waiting that minute in between, I pop my ears in, listen to their lungs. Do I actually need to suction them again? Never more than 3 passes, 1 minute in between. You would never want to suction for more than 15 seconds because now we're pulling away too much oxygen. Make sure, like, big important things for the trach is you never lie a trach patient flat. And we always have to make sure that the cuff is inflated. If your cuff on your ET tube or your trach is not inflated, then remember on your ventilator, you're going to get that low pressure alarm. It's going to start alarming. Burp, 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 burp. You're going to get a low pressure alarm because it's not able to deliver the breath because it's going in the atmospheric air. So is your cuff inflated? If it's not, do we need to get a hold of respiratory so we can evaluate that cuff? Do we need to change the ET tube or the tracheostomy? And then making sure that you secure the trach ties very well, 1 to 2 finger breaths around the trach ties, and that you're not, and when you change them, if you're by yourself, you're not taking the old ones off until you put the new ones on. Okay. Let's see here. All right, so let's go back to mechanical ventilation. Okay, because there's a lot of information about this yesterday. So let's look at our modes of mechanical ventilation. So assist control, the ventilator does all the work, right? So the ventilator is doing all the work, okay? The vent controls every breath. It controls the tidal volume, which is the volume of air that you breathe in and out with each breath. It controls the PEEP, so that's the air that's left in after you exhale. It controls the FiO2, which is the percentage of the oxygen that the patient is getting. It controls a guaranteed rate. And then just as a reminder, the patient can increase the rate. So let's say the rate on the ventilator is 15. The patients can breathe 20 times a minute. And remember, when we have our patients and we're setting them up in AC, your rate should usually be between 12 and 20 breaths per minute. They will increase it if they need to. Let's say your patient's on sedation or on a paralytic. Would you be concerned if the rate was only 6 or 8 breaths per minute? Absolutely, because that means they're not breathing at least 12 times a minute and they can't take more breaths anyways because we've either sedated them or we've paralyzed them, right? So we give them a guaranteed rate, and then if they need more breaths than that, they can take another breath. But as soon as they initiate their breath in AC, the ventilator kicks in and it takes over and delivers the breath. So remember, if you have an A on the ventilator, it's an assisted breath. The patient initiated the breath, the ventilator kicked in, took over, and gave the patient the breath. If you have a C, that means that the ventilator initiated the breath. It says, hey, it's been 4 seconds. You're due for another breath. You're not asking for one, but I know you need one, so I'm going to give it to you. Okay. So anytime your patients are on AC, I think multiple things. Number one, they're either sedated or paralyzed. So we have to breathe for them because they can't do it on their own. Number two, maybe they're going for a procedure. We're in the OR and we need to control their breaths. Or 3, they're really sick. So they're in ARDS, they're COVID, respiratory failure, but they're really, really sick. So now we either need to paralyze them, sedate them. We need to take control of the breathing so we can allow the lungs some rest and allow them to heal. Okay. Then, so AC is not a weaning mode. Remember, AC is not a weaning mode. Then we have SIMV, and this is a weaning mode, right? So half of the work is done by the ventilator, and then the other breaths are done by the patient. So this is a weaning mode. Vent does half the work, okay? So half of the time, the vent gives the breath, it gives the tidal volume, it gives the FiO2, it gives the PEEP, and then the other half of the time when the patient takes a breath, or anything, like let's say they're set on an SIMV of 8, okay? Well, that means that the ventilator is guaranteed to give them 8 controlled breaths where the ventilator does all the work. But if they're breathing 20 times a minute, those other 12 breaths, the patient's doing on their own. They're pulling their own tidal volume, they're pulling their own PEEP, they're pulling those breaths themselves. We're giving oxygen. So if they're getting an FiO2, they're getting the same FiO2 because that's consistent. And we're just giving them a little bit of pressure support. And remember, pressure support is just the support so they don't feel like they're breathing through a straw. So it gives them just a little bit of pressure so they don't feel like they're trying to breathe through a tiny tube. Okay, so 8 breaths would be controlled, like assist control. The other 12 breaths that they take, or 8 or 6, however many breaths they take over those 8, they're all pressure support breaths, meaning the patient's doing all the work. All we're doing is giving a little bit of pressure to make sure they don't feel like they're breathing through a straw. So then we come to pressure support, and that's all it is. Patient does all the work, right? So this is a weaning mode. So they're pulling their own rate, their tidal volume, their PEEP. We're giving oxygen and we're giving a little bit of pressure support. So if you might see a setting of pressure support of 8. It doesn't mean that we're giving them 8 breaths. It means we're giving them a support of 8 pressure. So the 8 means how much pressure we're giving them to make them feel like they're not breathing through a straw. Okay. CPAP is just like if they were on a CPAP for sleep apnea, continuous positive airway pressure. And we're doing that to kind of help keep the airway open. Remember, they could be on CPAP with a mask through the ventilator or through the ET tube or a trach. And it's very similar to pressure support. We're just giving a positive pressure to help keep those to help keep the airway open. And then you can have this pressure controlled inverse ratio. And this is kind of like assist control. The ventilator does all the work. So the ventilator is controlling the breaths. And the reason that the ventilator is controlling the breath is because we're flipping the inspiratory and expiratory time. So typical inspiratory and expiratory time is 1 second in, 3 to 4 seconds out. In this pressure controlled inverse ratio, what will happen is we'll have the patient will breathe 2 to 3 seconds in or 3 seconds in, 1 second out. So because we're making them breathe like they don't normally breathe, we've got to take control of the breath. And very often these patients are sedated and paralyzed. Okay. Let's see. If the patient is on a neuromuscular blocking agent, that's what that means. Neuromuscular blocking agent. You guys looked them up for clinical, right? So that would be your vecuronium. And the patient must be on a controlled ventilator. Okay. They must be on a controlled rate. So they need to be on the pressure controlled inverse ratio or the assist control. Okay. They have to be on those settings. Otherwise they're going to go into respiratory arrest and cardiac arrest because we're taking away their ability to breathe on their own. Why do we put patients on the ventilator? Well, we put them on the ventilator because they're going to OR. So they might be completely healthy, but like I said yesterday in class, maybe they're having a total hip replacement or something like that. Maybe they're in ARDS, right? So they're maybe they're really, really sick. The lungs are stiff. We need to try to control the breathing. Maybe they had a trauma and their brain isn't working very well, or we've had a spinal cord injury and the patient's unable to breathe on their own. So we have to give them backup respiratory support because of the neurological system. Maybe we have to paralyze them for something. If we're proning them because they're in really bad ARDS, are we paralyzing them? Yeah. I don't want somebody lifting up their head while they're prone and pulling out their ET tube, right? Maybe they have a higher work of breathing. Maybe we're putting them on the ventilator because they're breathing so hard. They're in status asthmaticus, right? They can't catch their breath. They're breathing. And now we know that they're going to go into respiratory arrest. So maybe we have to put them on it because they're increased work of breathing. Maybe they're confused. Maybe they stop breathing because they've overdosed on a medication, right? Or overdosed on a street drug. So now they're apneic because of that. So until we can reverse that drug, maybe we need to intubate them and provide backup ventilatory support. And then circulatory shock. And we talked a little bit about this yesterday. Remember, circulatory shock is you've got a low, you've got something that's decreased your cardiac output, and maybe you have like a low circulating volume, or your blood's not forwardly advancing the way we would like it to. So maybe we need to maximize gas exchange. We need to intubate them, mechanically ventilate them to promote the best gas exchange until we can correct the circulatory shock. Okay, so let's let's go back to problems. So if we have a patient that's on a mechanical ventilator, right? Almost any intervention that we give as a nurse or as a healthcare provider, there's a side effect or a complication that goes along with it. Let's just talk about bolusing patients with fluid. That's something we do all the time. But if somebody comes in, they have a decreased cardiac output. We were just talking about this in our question and answer session. They have a decreased cardiac output and we start bolusing them with fluid, and then we find out that they're in heart failure. Could that harm them? It might.
Yes.
So yeah, absolutely. So we have to think about that, right? So if we're going to mechanically ventilate these patients, guess what? It's not all rainbows and flowers. We have to think about all the things that go along with complications from mechanical ventilation. So can we cause a lung injury? Of course, right? If we give too much pressure, tidal volume, we're giving positive pressure into the lungs. So if I give too much pressure, too much tidal volume, too much PEEP, I can cause a pneumothorax, right? Or God forbid, a tension pneumothorax. Ventilator associated pneumonia. You have your own protective barrier, right? You have your nose, your upper airway that humidifies the air that you breathe in, that warms it. And you have the cilia and the mucus in your airway that helps trap bacteria and viruses so that you don't end up with a respiratory infection. If I take a tube and I bypass all those defense mechanisms, I have increased the likelihood that my patient can end up with pneumonia. I also have secretions that are flowing back down into that airway. We have patients that have an NG tube. So that means that our esophageal sphincters are open. So if we lay them flat or if they vomit, there's higher risk for aspiration there. So thinking about all those things that we need to do to prevent ventilator associated pneumonia. We talked about them quickly yesterday. Elevating the head of the bed 30 to 45 degrees, oral care every 1 to 2 hours, chlorhexidine, right? Making sure we turn the patients, listening to the lungs, turn the patients, encourage coughing, deep breathing, suction when we need to, right? So we've got to make sure we try to prevent those problems because we're causing the problem. We're the problem, right? We put the tube in to save their life, but now the side effects can be major for the patient. So we need to think about that. Decreased cardiac output, major problem, right? So we have somebody that's in circulatory shock that already has a decreased cardiac output. So we intubate them, right? So we can maximize gas exchange. But one of the side effects of intubating them and giving positive pressure ventilation is that we can cause a decreased cardiac output. So if that's the case, then I need to do what I can to try to look for that and try to maximize cardiac output. So if we've got a positive pressure, remember I talked about your lungs and your heart are in a cage, right? There's not a lot of room to move things around, right? So if you have positive pressure ventilation and we're overinflating those lungs or we're inflating those lungs and keeping a high PEEP there, then there's not a lot of room for that heart to expand or the blood to flow back to that cardiac silhouette. So do we have a decreased cardiac output? Yeah, because we might have a decreased filling. We also have to think about the fact that these patients are hypercapnic usually, right? So a lot of times if we have somebody that's really sick, they're hypercapnic, which causes massive vasodilatation. So our venous return is not nearly as good as well. If we have a bad cardiac output, then we have a decreased perfusion to the liver and the kidneys. So can we go into renal failure? Sure. Liver failure? Sure. Right. GI, we have to think about, once we intubate the patient, no one's like, hey, let's feed the gut right now, right? We're thinking about gas exchange. Rightfully so. We're thinking about cardiac output. Rightfully so. We're thinking about perfusing the brain, the heart, the lungs. No one's like, okay, how's the pooper? Did they move their bowels today? Right? What's the protein in albumin? No one's thinking about that initially. We're thinking maximizing gas exchange and perfusion, right? However, we know that stress causes ulcers, right? These patients are high risk for aspiration because our esophageal sphincters are open. If we're not feeding the gut and they're laying stagnant, maybe because we've given narcotics or we've paralyzed the patient so we don't have gastric motility, they might be constipated, so we can have problems there. So eventually we have to think about those. We have to think about the nutrition, right? I always think about this when patients come out of OR, right? Any of you guys that work on units where you're recovering patients or OR, everyone's like, are they breathing? What's their neuro status? Are they alert? Are they oriented? What's their blood pressure, right? No one's like, how's the pooper? Are we moving our bowels yet? Right? No one's thinking that first. 2 or 3 days later, we're like, oh crap, now this patient's distended. They're not moving their bowels. Now I have abnormal bowel sounds. They might be hyperactive on the top, hypoactive on the bottom. Do they have an ileus? Do we have a bowel obstruction? So we got to think about those things because that's a complication from mechanical ventilation and artificial airways. And then of course, damage to the mucosa. So do we have damage to the mucosa? Do we have an ET tube that's like laying against the skin? Do we have damage to the, I mean, I've seen ulcer breakdown around, oh, hold on guys. Okay, I thought it was gonna like, I'm still connected to the internet. I thought it was gonna cut me out. Just want to make sure it doesn't change your recording. Okay. You know, we can have skin breakdown, right? So cleaning out the mouth, right? And I just, when you guys are in clinical, I think this is a skill that students are afraid to do because you're afraid to mess with something. You don't want to pull out the ET tube. You're afraid to get in there and get all that fungus bagungus out of the mouth, right? Imagine you laying in bed for 24 hours and not brushing your teeth or taking a drink of water. What is your mouth like? Just think about when you go to bed, if you get 6 hours of sleep, you wake up the next morning, one of the first things you want to do is brush your teeth, right? Or take a drink of water because your mouth feels so gross. Imagine 24 hours having a device in there like braces or a retainer and not being able to eat or drink or not cleaning out your mouth. How gross and how that would feel. And then, you know, think about these patients that have that happen for days. And then, you know, the risk of ventilator associated pneumonia. So all things we have to think about keeping that oral area clean. And then, you know, same thing if you have a trach. Mouth care is still important when you have somebody that has a trach, but then making sure we don't have any skin breakdown around that tissue around the tracheostomy. So if we talk about our high pressure limit, remember we were talking about that alarm. So the high pressure alarm goes off, low pressure alarm goes off. Why? Why do we see that? Why do we see a high pressure alarm, low pressure alarm? So if we have a high pressure alarm, that means that the ventilator has to deliver a high pressure to give that breath, and that can damage the patient. So if we have a high pressure alarm, or if we talk about a pressure limit, something is pressing in against the tube. So maybe the patient's coughing against the tube, maybe they're biting against the tube, maybe there's a kink in the tube, maybe the airway is getting worse, right? So maybe they have a mucus plug like we were talking about in the class the other day. Maybe their lungs are really stiff. Maybe we have all these things that are going on that the patient's condition is worsening. That would cause a high pressure alarm. And you guys witnessed that yesterday when I was like pushing against the lungs and it was going burp, 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 right? And then a low pressure alarm means the ventilator is trying to deliver a breath and it's not getting any pressure back against it. So like the ventilator is delivering the breath and it's going out into almost the atmospheric air. The number one reason we see that is there's a disconnect somewhere. Maybe the ventilator has been disconnected from the ET tube or from the tracheostomy. Maybe one of the blue tubes that you guys saw in the class yesterday have disconnected from the setup. Maybe the cuff's deflated. You're going to see a disconnect. So if the ventilator alarms and the patient is not ventilating, if you've troubleshooted this, right? We went in, we suctioned, we listened to the lungs, we provided extra oxygen, and we can't figure out the problem, and the ventilator still cannot deliver the breath, you have to disconnect the patient and bag them. You have to be the ventilator, otherwise they're going to go into respiratory arrest. Okay, so it is your job, it is the priority of the nurse to make sure that that patient gets ventilated. And if the ventilator can't do it, then we have to ventilate. We have to provide that in and out movement of air so that they can have good gas exchange and oxygenation. Okay, so if we're going to wean the patients, we have to talk about weaning modes. Well, remember SIMV, pressure support, CPAP, and tube comp. We talked about that a little bit. That's where that like T attachment goes on there. Tube comp is a pressure support or is a weaning mode, right? We're not letting the ventilator do the work. We're asking the patients to do the work and we're evaluating their tolerance, right? How do we know that the patients are okay to wean? Well, they've had no major changes recently. Their output and their input is stable, right? We haven't had major overload intake or major overload of output. You know, our hemoglobin's greater than 8. The two things we have to think about when we're talking about good perfusion is our oxygen. Are we able to absorb oxygen, and do we have hemoglobin to deliver it, right? Everyone always says CO2, but CO2 is a waste. That doesn't tell me gas exchange. I could have CO2 build up because I'm not getting rid of something. Well, what's the problem? Well, maybe the alveoli are filled, or maybe I don't have enough hemoglobin to deliver that CO2 back to the airway. So hemoglobin greater than 8, respiratory rate greater than 10 and less than 30. What are the vitals, right? If they're extremely hypotensive, do you think it's a good idea to wean them off a vent? Nope. If they're in respiratory acidosis, is it a good idea to wean them off the vent? No, right? What are our electrolytes? If your electrolytes are all over the place or we've had major changes in the last 24 hours, we need to wait. What's our calcium? What's our potassium? Phosphorus, right? Phosphorus, if we don't have enough phosphorus, we don't have enough energy to wean off the ventilator. Are they agitated? What's their magnesium? Okay. We talked about this yesterday and a couple students asked me afterwards. So I think I said it wrong in class. And if I did, I'm sorry. Not that the recording is posted right now for you to go back and check it, but I will find it and repost it for you. The rapid shallow breathing index. We want the rapid shallow breathing index to be less than 100. The textbook says less than 105, but our respiratory therapists really don't even do it unless it's less than 100. So rapid shallow breathing index, we want it less than 100. And the negative inspiratory force, So the negative force is the lungs. The negative force is the force inside the lungs to drive the lungs to open up and breathe. So if the force is negative, the more negative it gets, the more force you have to take the deep breath, and that's a good sign. So we want a low or the more negative the inspiratory force gets, or the NIF, you'll hear us talk about the NIF, the better, because that tells us that there's that force and that drive to breathe for the patient. Okay. So that is, before I go on to like our status asthmaticus, PE, and like our surgical trauma or respiratory trauma, do we have any questions about ventilators?
I have two questions.
Please.
The first one is probably the difference between CPAP and positive pressure support is that CPAP is continuously giving pressure.
Correct.
And the other one just, okay.
With each breath. Yep. So CPAP will be a continuous pressure that supports the breath, but it's continuous. It's kind of trying to leave those alveoli open a little bit to promote gas exchange. So it's giving a continuous positive pressure, where pressure support is only giving the pressure to support the breath when the patient takes the breath. So in between breaths, when we get back to that baseline and there's that pause, there's no pressure there. And then when that trigger gets initiated and the patient starts to take their next breath, then pressure support is given.
Okay.
Does that help?
Yeah, I think I have another. Well, I'm not done yet.
You're right.
What is the SIV is the wean that gives
SIMV. Yep.
Now, if we program it, we're going to tell it to, are we just telling it to give volume and oxygen, or are we telling it how many they need? Like we want it to help on 8 breaths, right?
So on the 8 breaths, so we program, you're going to get 8 breaths. This is the tidal volume that you're going to get with each of those breaths. You're going to get this much percentage of oxygen. So we order an FiO2 of whatever we decide, 40, 50, 60%. Hopefully it wouldn't be 100%. We wouldn't be trying to wean the patient if the patient needed 100% oxygen, right? That would tell you the lungs are still too sick. So we would say the rate. So 8, 9, 10, 12, I usually say SIMV of like between 8, 10 or 8 and 12. So they're guaranteed to get 8 breaths that minute with a specific ordered tidal volume, 400, 500, whatever by their ideal body weight, and FiO2, whatever percentage, 40%, 50%. And we give them an ordered PEEP, like a PEEP of 5. Okay. So we order those for those 8 breaths. So they get that every single time the ventilator gives them one of those ordered breaths, they get that. Any breath that they do in addition to that is just a pressure support breath. We just give a little bit of pressure to support the breath so they don't feel like they're breathing through the straw.
That seems very similar to AC though. I mean, I know these are all kind of like, there's not huge differences between them, but that kind of seems what it's doing in AC.
IMV is very different than AC.
Now, I thought AC is after 3 or 4 seconds, if you don't take that breath, AC says, boom, you have to take a breath. Correct. And it gives it to you.
Correct.
So, and then 4 seconds after that, if you don't inhale or the person on the vent doesn't inhale, it says, boom, there's your breath. Am Correct. I right?
Correct. Okay. IMV is going to be the same in that instance. So let's say you have 10 breaths. Okay. Let's say that they're ordered an SIMV of 10. And so that means every 6 seconds, the patient's going to get an ordered scheduled breath, just like assist control. Okay. But any breath that they take after that the ventilator is not giving them a tidal volume. It's not giving them a PEEP. It's only giving them oxygen, and it's giving a little bit of pressure support to support the breath. In AC, let's say we order them a rate of 15. Okay, let's do it the same. So let's say SIMV, we give them a rate of 12. So those 12 scheduled breaths are going to be done by the ventilator. Anything that they breathe past those 12 breaths are just going to be a supported breath with a little bit of pressure support. So we're not giving them tidal volume. We're not giving PEEP. We're only giving oxygen and a little bit of support to support the breath. So they don't feel like they're breathing through a straw. But all those other breaths, if they breathe 20 times a minute, they're ordered 12, those extra 8 breaths, the patient's doing all the work themselves. They're pulling their tidal volume. They're pulling their PEEP. They're pulling all of that. We're just giving a little support so they don't feel like they're breathing through a straw. Let's say in AC, we give them a rate of 12. Okay. So they get a rate of 12. You look at the top and you see that they're breathing 20 times a minute. Those 12 breaths are scheduled. Those 8 extra breaths that the patient asked for, we're still giving the tidal volume. We're giving the PEEP. So essentially all 20 breaths are the same.
Gotcha.
In SIMV, 12 breaths are going to be the same, but anything they do past that, the breath might be very different. They might only pull a tidal volume of 200, even though they're ordered 500. They might only pull a PEEP or hold a PEEP of 3, even though they're ordered a PEEP of 5, because the ventilator's not giving them the PEEP. They're doing it on their own.
What triggers the ventilator and the SIMV to turn on and give it one of those forced breaths? Because I'm
Usually it's
imagining
just
laying
timed.
there. Well, because if
Usually
I'm
it's just
laying there,
timed.
what if I'm like exhaling and the machine decides it's time to take a breath?
So the machine is smart and it's going to sense that the patient's exhaling.
Okay.
Yeah. Mm-hmm.
I mean, I've never really seen one of these in action, so these are kind of like things that I'm thinking of.
Sure. Now, when we talk about the patients fighting the ventilator, it means that like the patient might be getting a scheduled breath, okay? And now they're trying to breathe on top of that scheduled breath. So the ventilator is already delivering the breath and the patient is trying to initiate another breath on top of it. Or they're trying to exhale when the machine's trying to get them to inhale.
Understood.
So
And then the machine would alarm in that case.
For if they're fighting the ventilator, yes, it would alarm. Yep.
like say if you're on the SIMV and then you have 6 breaths a minute, and so it's timed every 10 seconds, they're gonna get a breath. Like on second 9 of that cycle, they start breathing. So it's not going to count that breath that they're doing. Will it wait for them to breathe, then give them another breath and like readjust so it can still give them 7 more breaths in the rest of the time?
Correct.
Okay, so it'll just keep like
adjusting.
Okay.
So is CPAP and BiPAP more like pressure support in that way and less like SIMV?
Yes. In CPAP and BiPAP and pressure support, the patient is never given a rate. Like in SIMV, they're giving a rate because they're guaranteed to get so many breaths per minute. In AC, we're giving a rate because they're guaranteed to get so many breaths per minute. But in pressure support, CPAP, BiPAP, we don't set up a rate because the patient initiates the breath themselves. They initiate their own rate. So this is why I forget, gosh, who was in the classroom? They were saying yesterday, I can't even remember who it was. Usually I'm good about that. They said, oh my gosh, they told me not to go far to watch the patient. Because what if you flip your patient to pressure support and 15 seconds goes by and they don't take a breath? The ventilator is not going to tell them to take a breath because it's not set to give them a breath. All it is supporting the breaths that they take. So that's why when we flip them to IMV or pressure support or CPAP, we're always like, okay, watch them closely, because if they don't take a breath, then we know they're not ready to wean because they're not even initiating their own breath. They're not even trying to take a breath.
So they'd immediately go back to an assist control then probably, or
it would be up to the provider, whatever they would decide. Yeah.
Hey Jill, I have a question about the tidal volume. So like yesterday, like on the slide it says like 6 to 10 for like normal and then like 4 to 8 in like ARDS, but like you keep saying like 400. Is that like in the hundreds and it's just like
so on the slide it says 6 to 10 milliliters per kilogram. So if you had somebody that weighed 80 kilograms and you ordered and it was ordered 8, so let me calculate this out. So just to give you an example so you understand. Okay, so if you had somebody that had that weighed 80 kilograms and you were ordered 8 milliliters per kilogram, your tidal volume would be 640.
Okay, that makes sense.
Does that make sense? So you would
Yeah.
just take that 80 kilograms and multiply it by 8.
Okay, thank you.
Okay. So I give you that because that's the prescription for it, but you guys aren't going to see that prescription. So when you go to clinical, no one's gonna be like, hey, they're getting 6 milliliters per kilogram tidal volume. They're not going to tell you that. You're going to go to clinical and they're going to say, hey, their tidal volume is 500. And you're going to say, oh, somebody already calculated that out. They took their kilograms and they multiplied it by 6 or 8 or whatever the prescription was by the provider. And it came out to 500 or 600 or, you know. The thing I want you guys to think about is tidal volume is if we give too low of a tidal volume, are we forcing the lungs to inhale as much as we want them to? No, it's like alveolar hypoventilation, right? If we give too much tidal volume, what's going to happen? We're going to cause a pneumothorax because now we've overinflated those lungs, right? So I just give you that range of like 4 to 700, 4 to 800, because most people fall in that range because we're doing it by ideal body weight. You know, so if their ideal body weight's 80 kilograms, then we say, okay, this is what we would expect their tidal volume to be. I just give you that guys that range because if you go in and you see somebody's on a tidal volume of 1,000, I'm like, whoa, why? Why are we on a tidal volume of 1,000? That's really high. Or if I go in and I see a tidal volume of 200, I'm like, there's no gas exchange there. We're not even inflating those lungs. Like they're breathing like this, right? We're not inflating the lungs if we have a tidal volume of 200. So I just give you that reference range because I want you to be able to recognize and question the abnormals. Does that help, Kylie?
Yeah, thank you.
Sure.
One more question, ma'am.
Yeah.
What's RSBI?
That's the rapid shallow breathing index. So if you go back to the weaning parameters on the slides, you'll see like what the respiratory therapists look at. And the respiratory therapists look at the negative inspiratory force. They look at the blood gases and all that too. And they look at the rapid shallow breathing index. And you'll see on the slide, it says less than 105. It should be less than 100.
Yeah, but like, what is it? Or is it
Oh,
just
it's
something they calculate?
It's a calculation. That's a calculation that they do. And they look at the index of the chance of them having rapid shallow breathing. So if the index shows that there's a greater chance of greater than 100 or 105, whatever that calculation means, which I don't know.
Okay.
Yeah. Then I'm like, oh, then that means that they're more likely to have this rapid shallow breathing, which we know is not going to be good if we take them off the ventilator, because that means that they're not taking deep breaths in, they're alveolar hypoventilation, they're tachypnic, they'll be tachycardic, and they're going to end up re-intubated. What else?
Body weight, they just are taking their height and then they take like another measure, whatever other measurements they need from the person, and they calculate what like their normal, like basically like a normal BMI or something, like what they should be like in healthy weight.
So you could go online and look at a body structure, like that. You could go on and look at like what should your ideal body weight be, and they'll look at your height and your body structure and say, if you are this tall and you have a like small structure, this would be your ideal body weight. They give you a reference range, and that's what they use.
Okay, thank you.
Mm-hmm. How are we doing? Okay. Is this helping? Going over this again?
Yes.
Okay. Any more questions before I go to respiratory trauma? Okay. So remember, these are all conditions that you pretty much have studied somewhere along the line here at Mercy College. But now these conditions have gotten worse. Now we're taking them in an ICU emergency situation where they've gotten worse, right? So you guys have taken care of status asthmaticus, or you guys have taken care of asthma patients. And now we have the asthma patient that has, that's gone bad. So you're traditionally treating this asthma patient, and now the conservative treatments are not helping. Okay. So, you know, status asthmaticus is these patients have, and usually this could be brought on by a trigger of an environmental stimuli or something like that. But we look at these patients or the situation and we say, okay, status asthmaticus, I've given the patients are already on their inhaled corticosteroid, their regular treatment that they get daily, and now they're short of breath. And now we're giving albuterol and they're still feeling short of breath. They're like, I did my albuterol, I don't feel better. I did it again, I don't feel better. Now we're in status asthmaticus because the conservative treatment that usually works is not working. Okay, so now they come in and guess what they're going to look like? Tachypnic, tachycardic, hypoxic, anxious, right? They're super anxious. Anybody that's had an asthma attack knows you feel anxious because you can't breathe. You feel like you're suffocating. And now they're even more worried because the things that normally help them aren't helping them. So they come in, we recognize it's status asthmaticus. We're not just inhaling like like doing an inhaler. Inhaling, you're not just doing an inhaler like take 2 puffs of your albuterol. We're doing a nebulized, constant albuterol the whole time they walk in the door. Okay, albuterol. And then we say, okay, do we need to use our steroids, right? So do we need to use steroids? What caused this status asthmaticus? Are they having a reaction to something? Would they benefit from epinephrine? Epinephrine works on beta 2. It's going to bronchodilate. So could we give epinephrine? We're giving albuterol, which is a SABA, bronchodilates. Steroids, potent anti-inflammatory. We can give them IV, we can give them inhaled, right? So potent anti-inflammatory. So we can give our steroids. But we need to remember that if we're doing these things and the condition of the patient is starting to still continue to decline, the smart nurse in the back of their mind says, I'm planning on intubating this patient. I can intubate them, put them on a ventilator, and whenever the edema and the asthma attack goes away, we can extubate, no problem, right? But we need to make sure that we protect that airway because if it closes off, now I can't get a tube down there and we have to do an emergency tracheostomy, which is a surgical, you guys know from the lecture, it's a surgical incision in the neck. Most of the patients that come in that are in status asthmaticus end up in the ICU. Now, help me remember, so Michael and Nicole, when you guys were in my clinical group, oh my God, what semester was that? Summer? And I think Kylie, I think you guys were, I can't remember who was with me that like Jay, you were there. Did we have a status asthmaticus patient on that unit? I feel like we did one time.
Not that I remember.
I remember a status asthmaticus patient somewhere in clinical, but they were not, that's what they were brought in for, but like they were
Stable
from it.
Okay. Well, there was a patient that, and I thought it was maybe when I had you guys in the summer, whoever was in my clinical, like everybody that was in my clinical group, I can't remember. And I think like Jake was in my group and Jay, Kylie, I don't know, whatever it was. But there was a lady in room 11 and we were on 7 West Extension. She was a nurse and she came in and she was status asthmaticus and they ended up calling a rapid response team on her then. And they ended up sending her to the ICU by the end of our shift. But she was a nurse, she was semi-stable, but even after they provided all these interventions and we felt like we had stabilized her, her asthma attack continued to continue, and they were worried that they were going to have to intubate her. And as soon as they called the rapid response team, they were albuterol, steroids. I mean, they were giving her the whole gamma. So I just want you to recognize that it is an emergency. Albuterol is first line treatment. We've got to think steroids. You know, you'll hear other people talk in the literature about like Singulair and maybe magnesium, right? Because you guys remember magnesium. If you give magnesium to somebody that's in labor, what does it do? Stops contractions, right? You guys remember fluid and electrolytes? Magnesium relaxes the muscle. So if you have somebody that has an airway that's really tight and the muscles are constricting the airway, if we give magnesium, does it relax? Yeah. So sometimes even magnesium will work. However, first line, I want you to think, what do you have to do first to save their life? You better give albuterol. In the back of your mind, you're thinking of providing an airway. We're giving steroids, but we have to back up ventilate and keep the airway open. Epinephrine to prevent that airway from closing off. That's the down and dirty of asthma. And of course, oxygen. If there's ever a question that says, should I give my patient oxygen? Always pick it, right? We can stop the oxygen, but does it ever, like, if we give them oxygen initially, does it ever kill anybody? No. Could they end up oxygen toxic? Yeah, but they have to get high doses of oxygen for a long period of time for that to happen. So if there's ever a question that says, should I give my patient oxygen? When in doubt, pick it, right? That's a smart answer. Pulmonary embolism, right? So now we have a DVT that's gone bad, that's traveled to the lungs, right? And you guys know that a pulmonary embolism is now going to occlude blood flow. That's going to inhibit good gas exchange, right? So now we've got a pulmonary embolism. We've kind of infarcted part of a lung. So now we've got a gas exchange problem. We're going to have that shunting, right? That blood's going to come back to that left ventricle that's not participated in gas exchange. These patients end up with, they can have hemoptysis. They're short of breath. They have impending doom. Every single one of these situations, your patient, so don't memorize this. They're anxious because they're hypoxic. They're hypoxic. They have, they're tachypnic, they're tachycardic, they're dyspneic, right? Don't memorize that for each one of these conditions. You know it. Every single patient that comes in with these problems are going to have those symptoms, right? So look for the clinical manifestations that stick out. So PE, they're going to have hemoptysis, right? They're going to have chest pain. They're going to be hypoxic in really short of breath, and we don't know why. So what do we do for these patients? Well, there's a lot of things we can do, and we have to look at their underlying history. So first line therapy, we got to give heparin. We want to stop the clot from getting bigger and from traveling somewhere else. Depending on contraindications, we might have to give a clot buster. So we might have to give like TPA and go in and break up the clot. Remember, heparin and TPA are totally different. Heparin is a blood thinner. It thins the blood. It does nothing to the blood clot. It does not break it up, right? A clot buster like TPA is going to actually break up the blood clot. We might have to do an embolectomy where we go in and actually remove. So they can go to interventional radiology and they can go in and try to remove the clot. They can go in and put a vena cava filter in, right? So if we see that they might have an ultrasound of their extremities, we see that they're coming from the lower extremities, the clot's traveling to the lungs, they might put in a vena cava filter to prevent anything else from traveling up there. And then of course, oxygen. If they're really, really bad, we might have to do ventilation support to maximize gas exchange. So that's your PE. Flailed chest. This is where the patient has 2 or more ribs broken in 2 or more spots and the ribs are floating, right? So if I had a flailed chest on this side, my ribs maybe I have like rib 3 broken here and here, rib 4 broken here and here, rib 5 broken here and here. So this segment of ribs is floating. And what happens is when I take a deep breath in, my lungs inhale, right? So they expand. But this part of the lung doesn't. It doesn't come out with the rest of the cage. As I take my breath in, this part of the lung goes in with it. So you have that paradoxical chest movement. So I breathe and I'm like, well, guess what? The lungs don't expand well. They don't expand well, and it increases the work of breathing. The patients are working so hard to take a deep breath. They're not pulling a good tidal volume. We have alveolar hypoventilation because they can't get the lungs to expand very well because they're working too hard. We also have a gas exchange problem because we have pulmonary contusions. These patients don't just cough and have a flailed chest. They were part of some kind of trauma. They fell down the stairs. They fell and slipped on the ice. They were in a motor vehicle crash, motorcycle accident, some kind of trauma where some kind of impact hit that lung. Well, you guys know, if you just walk in your living room and you hit your elbow and 2 days later, you're going to have a bruise. Same thing's going to happen in those lungs. We're going to have bleeding into that area. So we have contusions or bleeding into that area of the lung, which also inhibits gas exchange. So you have somebody that has a flailed chest that has increased work of breathing. Guess what they need? A ventilator, right? Like a chest tube is not going to help them. Do they have bleeding in that site? Yeah. Do they maybe need a chest tube? Maybe. But does that change the work of the breathing? No. Does it help them pull a good tidal volume? No. They usually need a ventilator. So you're thinking of, these patients will tucker out, they'll become hypoxic. Again, dyspneic, tachycardic, hypoxic, they'll end up hypercapnic. They're dyspneic, they have terrible pain. Don't tell me you're going to go in and give them pain for their rib fractures. Pain medication is not going to save their life, right? What's going to save their life? I need gas exchange. So intubate, mechanically ventilate these patients. Tension pneumothorax gone bad, right? So now I have somebody that for some reason, some kind of trauma, stabbing, some kind of shrapnel, something has caused this lung to puncture, and the atmospheric air from out here is invading the thoracic cage, right? So now we have air seeping into the cage. Every time that negative inspiratory force is pulling air into the lungs, it's pulling atmospheric air into the lungs from the outside through the chest wall as well. So air is building up. Guess what? Now I have a lung that's dropped. Guess what? Now my cardiac silhouette's being pushed over. Guess what? My PMI is being pushed over. Guess what? My trach is being pushed over. So you'll have a tracheal shift or deviation away from the side of the injury. PMI away from the side of the injury. If you listen to these lungs, you're going to have absent breath sounds on this side. Is the lung expanding? Nope. Can you hear breath sounds over here? Nope. You percuss that baby, it's going to be hyperresonance because this is filled with air. Not good gas exchange air, atmospheric air that has collapsed this lung. These patients will have terrible chest pain radiating to both shoulders. They radiate to both shoulders, tracheal shift away from the side of the injury, PMI away from the side of the injury. You better be running for a chest tube. It's the only thing that's going to save their life. Usually they do a 14 gauge needle to really alleviate the air, but they need a chest tube. They need a chest tube. We need to get rid of the fluid if there's any that is built up in that area, but we need to get rid of that air. Okay, so 14 gauge needle, chest tube to follow it. It will save their life, and you'll hear it. You'll hear it. If anybody's ever been able to witness a chest tube being put in place and air is the cause of the need of the chest tube, not blood or fluid, as soon as that chest tube goes in, you can hear it. Psst, it literally will relieve it. And then let's go over our lung surgeries again. So, you know, there's all these different lung surgeries that you may take care of. They might have a wedge resection, which they're just taking out a wedge of part of a lung, a segment, taking out a segment of a lung, a lobe, taking out the lobe of a lung. But a pneumonectomy, they're taking out the whole thing. Okay, so they're taking out the whole thing. So you're losing the whole lung on one side. And if you do that, now this area that where the lung was is filled with fluid that kind of becomes gelatinous that encompasses that space. So we don't have a tracheal shift one way or the other. So if you have a patient that you have had lung surgery, except a pneumonectomy, they've had lung surgery, segment, wedge, lobe, something removed from the lung, and we put them in a position to maximize gas exchange, we put good lung down. So if I had a segment taken out of here, I'm going to lay the patient on their left side, even though the surgery was on the right, to maximize gas exchange over here. If the patient has had a pneumonectomy, we don't do that because all this fluid that we want to encompass this space is going to put pressure against that lung. And now we're going to have bad gas exchange. So good lung down unless it's a pneumonectomy. Also, if they have a pneumonectomy, we have a stump that's there. So major complications is we can use a suture, lose a suture on the stump, so they could bleed. They could develop a fistula, which means that they have an abnormal connection from part of that airway to somewhere else in the body. The other thing I always think about too is after we have to be super careful with suctioning patients after they have lung surgery or pneumonectomy, because if you take that suction catheter in there and you jam it down far and it goes past the carina and into the area where the lung is removed, where that stump is cut off, can you bust open that suture line? Yeah, for sure. And now they're going to bleed for that. So remember, good lung down. If we're trying to promote gas exchange, we want good lung down in almost every case except for a pneumonectomy. Okay, pneumonectomy, we want the lung that was removed, that area down, so we can allow gas exchange to occur over here because we don't want to put this kind of pressure against that lung. Okay, questions? Okay, so I'm going to stop sharing. And I'm going to stop.
I just had a quick one about HCI though. It's